Hello, everyone, and thank you for joining us today. My name is Natalie Boyum, and I am the president and founder of the Defeating Epilepsy Foundation. We are a 501c3 in Southern California, and our mission is to provide the advocacy and educational resources needed to the epilepsy community and our society. Today, our guests are Dr. Raman Singh and Aliana Gordon. Dr. Singh is a recent medical school graduate who is applying for neurology residency in the U.S. Dr. Singh completed an 8-week EEG epilepsy course at University Hospital's Cleveland Medical Center after graduation and is now a volunteer epilepsy research associate at Kaleida Health, University of Buffalo since October of 2020. Aliana Gordon is a pre-med student from the University of Redlands and our lead research intern here at our foundation. Dr. Singh and Aliana, I want to thank both of you for joining me and taking part today.
My pleasure.
Thank you.
Thank you. It's an honor.
Thank you. So, Dr. Singh, can you give our guests a little background of your education and the work you do?
Sure. First of all, Natalie, I would really like to thank you for the introduction. It was really kind of you. And at the same time, I'd really like to thank you for inviting me to talk on different aspects of epilepsy, because I believe epilepsy is it's a broad topic, very complicated topic. And managing epilepsy kind of necessitates it's like multifactorial. It's not just like doctors, it's like a whole team treating one patient. We're going to talk about that in detail. Coming to my educational background, I'm a medical school graduate. I graduated in 2019 from India. I'm half Indian. And after that, during my medical school, during the third year, I became interested in neurology. And since then, I've been building on my experience in neurology so that I can have it as my career in future.
Oh, that's wonderful.
Yeah. So I've done a few clinical rotations, inpatient and outpatient rotations in various fields of neurology. And most recently, I have done the EEG epilepsy course at Case Western in Cleveland. It's a very intensive course, and it teaches medical students, even like different neurologists who are not very, familiar with epilepsy. It would be an add-on for them to know like how epilepsy is and like how to read EEGs, which is a topic that I feel is sort of neglected during medical school. When you learn
I'm glad you brought that up, because what has been so interesting is, first, I love how you brought up the fact that this is a team effort. Myself having epilepsy, and when I was younger, there really was no team there. It was my neurologist telling my family, give me my medicine if I have a seizure, to call an ambulance if I went to status. There was no team to really help when it came to mental well-being, with development, things that were happening. And I'm so glad to see in the medical field now how much doctors are now seeing they can't juggle all the balls themselves. They have to work with others in best interests of the patients. And I also love the fact that you brought up that learning about EEGs and epilepsy when it comes to neurologists, they really do need it, because I've had a number of neurologists over years who you could tell their focus more is something like Parkinson's disease, and you get referred to a neurologist and you're thinking, okay, they understand what epilepsy is, but if their specialty really isn't, but that's an area, I find that it almost doesn't make it a difficult relationship, but what you really need from that person, they may not be able to provide to you.
True. So after my course at Case Western, I've really liked epilepsy. As I said, it's something that you really don't get to encounter during your medical school. So you would never get the chance to develop an interest in that field until you actually do it in detail, which is the course. So I thought, like, why not build on my experience even more? And I'm currently at the University of Buffalo, Kaleida Health. I'm working at the EMU, and I've been reading EEGs. And so that's pretty much what I do right now. And I've been working with attendings, and then we come on different surgical, we also have something called surgical conferences for a lot of patients who have a focal sort of epilepsy. Now, I know like epilepsy is a very broad topic, but in general, like it's either generalized epilepsy or partial. So like there's a certain area in your brain that might be generating something, like electrical activity that is causing those seizures. So these are usually amenable to surgery, and that's why we do have surgical conferences that would deal with such cases if medications are proven to be ineffective with them. So that's like in brief what I'm doing right now.
That is wonderful. What are the challenges you face when it comes to doing your work?
Yeah, thank you so much for asking me this question. Actually, it's a very, very broad question. Challenges are many. As I said, managing epilepsy is very multifactorial. So every factor has sort of its challenge. But I'm going to break the answer down into like a few like smaller sub-answers, let's say. So the first thing is epilepsy itself as a concept is challenging to understand and to explain. So usually a lot of times epilepsy is sort of used interchangeably with seizures, not with doctors, of course, because doctors who specialize in this field or like prospective neurologists, or they know that it's not the same thing. So what I wanted to point out here to like the general public, to our spectators, that probably, seizures are a subtype of epilepsy. Now, seizures, by definition, there's disturbance of electrical activity in the brain, but that's not exactly what it is all the time. Seizures, I would say, according to my thought, that seizures can be convulsive activity, can be anything simple from just behavioral arrest, which is a type of seizure that we see in children called absence seizures. These are all called seizures, but they do not necessarily have to be related to abnormal electrical activity in the brain, which we see in the EEG, electroencephalogram. Because seizures can also be due to can occur secondarily to different causes, like metabolic abnormalities, mainly electrolyte abnormalities. So that's like hyponatremia, which are like very correctable causes of seizures, and they do not have a definitive appearance on the EEG. It's not like a definite epileptic disorder as such. And finally, which is like the most difficult condition, is psychogenic non-epileptic seizures. These are also called seizures, and they may very well look like epileptic seizures, which is epilepsy. So epilepsy, in short, is electrical activity disturbance, actual disturbance, or non-electrical activity in the brain. But all of them need like the different modalities to treat them. And this is a very broad topic, as I said, but it's very challenging for us to be able to differentiate between the three sort of broad classifications that I've mentioned. That's one challenge. And the challenge to differentiate between them is a big thing too, because usually people with seizures status, they come to the emergency department. The first thing that is done is like you draw blood and then you check for abnormalities like sodium, potassium, electrolyte abnormalities, pardon me. So it's like you get to rule that out. If that's not there, then you have to think of the other two causes, whether it's real epilepsy or it's a psychogenic thing. So for that, a detailed history is very important. And you usually proceed to a 20-minute routine EEG, which is a reading for 20 minutes. I've been reading a few EEGs, but that does not usually give you conclusive evidence that you have something wrong in your brain. A lot of times, those patients have to be admitted to our epilepsy monitoring unit. Usually they come on a Sunday and they stay until Friday for 5 days. And this is where we actually monitor them like step by step and daily basis to be able to see if there's any abnormalities, epileptiform abnormalities like discharges or any seizure, actual seizure. Electrographic seizure is what we call it. So you see it on an EEG and you see it clinically. As compared to psychogenic, which you just see clinically, might resemble a seizure, even though like once you experience, you get to realize the difference between both, whether it's psychological or actual seizures. But yeah, so, but it doesn't have any abnormality on EEG. So that's one of the main challenges in that. Um, Apart from that, you want to say something, Natalie?
Yeah, I was going to say, I don't know a lot about the psychological seizures. In studying them and learning to read about them,
Yeah,
what are the major triggers for something like that? Mine that I have are due to a traumatic brain injury, but I've known that there's
yeah.
things such as pseudo seizures where they're having seizure activity, but it's not considered an epileptic seizure.
Yes, as you mentioned, traumatic brain injury is actually epilepsy. So
Mhm.
you've actually, there's something wrong in the brain, the tissue has been damaged, and because of that, it might start discharging or like giving abnormal electrical activity. And this can actually lead to epilepsy, especially focal, because usually the brain injury is most likely focal. So that's actually epilepsy. But those psychogenic seizures are totally different. They're not related to brain injury. They're related to psychiatric disturbances. I would like to talk about probably it's PTSD or anything psychiatric can lead to such things as well. Um, a lot of psychiatric disorder. There's no such thing like, for example, like depression can lead to that, or this can lead to that. It's just called psychogenic because there is a psychiatric background to it, but not actually an organic cause in the brain causing this epilepsy.
Oh, that's really interesting because I know myself being in some of the support groups and people when they have this the non-epileptic ones, because it's so hard to diagnose them, they actually have some of the biggest frustrations because they feel they can't get the support, or even at times that they're not believed because you really can't find the evidence to them. But it's good to see that they're doing the research to find more about these types of seizures.
Definitely. And like, but then I think the most difficult case is when the patient has both actual epilepsy and psychogenic seizures as well. And this is like often very hard to treat. Um, so usually a lot of, not, I wouldn't say a lot, but some patients, they get admitted to our epilepsy monitoring unit thinking that they initially just had psychogenic seizures and their EEG has been reported as normal before. They come to our unit and you see that they're like non-epileptic events and you see there's nothing on the EEG. But then when they're sleeping, or usually sleep is when that period where you get discharges going like a little bit more frequent, not in all epilepsies, but the discharges have the tendency to come out during sleep. So
Oh,
that's what
wow.
we're all monitoring. Yes. So then you see those discharges, and then probably after 2 or 3 days in the EMU, well, they get a generalized tonic-clonic seizure. So, and then they never knew about it. So it's like, then you definitely need to treat them with anti-epileptic drugs. Obviously, a psychiatric consult, even neurology, we can help them as well with like the psychogenic seizures as well. They have usually both the components. Those patients are very difficult to treat, but I think epilepsy, like if you actually have an epilepsy disorder, it's very damaging to the brain, and treating this is much more important, I feel, than the other psychogenic component, because that actually physically damages your brain, the seizures.
Oh, no, absolutely. And just out of curiosity, one thing they had me do to measure the level of damage years ago, because I have cognitive impairment, they had me do a psychoneurological test. For people who have psychogenic seizures, could something like that be beneficial to see what could be a possible trigger to these seizures?
Um, Not really, because neuropsychology tests are usually done. For example, if, as I mentioned earlier, there's some patients who have like a focal component of epilepsy, a certain area in the brain. And that area, if proven to be epileptic, and if medications are not working, I would like to mainly, I think it's like temporal lobe epilepsy, which is a very common type of epilepsy. Um, so they're potentially surgical candidates because it's not a generalized, but like there's a small segment of the brain that you would want to remove or resect, that would probably treat the seizure, and then the patient can be seizure free. Neuropsychology testing aims at basically testing all the areas of the brain so that if that area is to be resected, the sort of like language damage or cognitive damage is not that severe that like would be compromised with surgery. That's the main aim for neuropsychology.
Okay.
Yeah, yeah.
Because I was told by a previous doctor that I wasn't a candidate for surgery, but they actually did the neuropsychological test for me, and that was how they found out about my PTSD. It was one of the resources they used to officially diagnose me because of
Mhm.
the seizures. I have seizures in both my frontal and temporal lobe, and because of the seizures all the years, activity in the temporal lobe, it's caused by hippocampus to shrink, and that's where I
Yeah,
was getting the cognitive impairment from. So
yeah.
it was a very long test, but was a very interesting test because it really it answered a lot of things
That's
that I didn't
everything. Yeah,
understand.
yeah,
So I think it's great how they bring those together. But you were mentioning the epilepsy monitoring unit that you're working out of in Buffalo. And
yeah.
I did some research on it. It opened in 2017, and myself, I lived in Buffalo till 2009. So to see that there is a monitoring unit there now, yeah,
Uh-huh.
I was really happy to see it. Do you feel that with this investment that has been made in the community, that the doctors, the universities, other people are taking epilepsy more seriously, and that we can see treatment improve for patients?
Most certainly. Our epilepsy monitoring unit at Oshai Children's Hospital is a 12-bed epilepsy unit, and then it's highly equipped, whether staff or equipment. And I really appreciate the work of every single person at the epilepsy monitoring unit, starting with the techs who have done a very great job and like hooking up patients, making sure that we read all the attendings and fellows like me would like read the EEGs like without any problem, read it smoothly. Because as you know, like EEGs, like you read very long clips, and then the job of the text is to sort of like make the clips a little bit like smaller because it's not possible for someone to go through like a 24-hour recording minute by minute. So their job is to clip and take out the important data for us to read.
Oh,
That's
interesting.
Yes. And apart from that, I would like to thank the nurse practitioners because, um, when patients are admitted to the epilepsy monitoring unit, we usually sort of withdraw the seizure medications that they've been taking. If they were previously diagnosed with epilepsy, to possibly assess whether we need to increase the dose of the medication or whether to taper off the medication or whether they don't need medications anymore. So not letting them be on medications is sort of dangerous, but it gives us a lot of answers because when they get a seizure, we get to see what's going on in the EEG and accordingly we can treat. So the nurses there, whenever the patient gets a seizure or something, they're like the first ones to like do all the necessary precautions so that the patient would not like bite their tongue or sort of very different things like harm himself or like just fall because there are different type of seizures in which the patient can lose tone and fall. So the nurses are always there. They're on guard basically to um, prevent all the complications and keep the patient stable. And obviously the attendings who every day, like they're working day and night, they're, rounding on patients and then they're like giving the necessary treatment, giving the necessary advice for the patients and their parents as well. So, so it's a collective effort, and I believe that yes, it has become like very very advanced, especially with like the really well qualified epileptologists that we have in our unit, and everyone else who's been helping, sort of managing epilepsy overall, comprehensive. Yeah.
And it is a very challenging thing to do because I mean, myself, I haven't been in the EMU, but for the stories I've heard of others, the first step just coming off the medication for them to be able to see seizure activity, that's so scary for so many patients to begin with. So you have
Yes.
patients who are coming in who are already anxious, who don't know what's going to
Yes.
happen. Are they finally going to find the answers? So trying to keep some level of normalcy on the floor for all these patients to ensure them they're safe and that this is going to help them, that's quite a bit of work in itself right there. And then
Yeah.
just the thought of 12 patients on the floor and you're running around the clock, keeping an eye on these people and knowing at any time the alarm can go off and they could be
Yeah.
seizing, that's a incredible job. That takes somebody very special.
Yeah, I mean, that brings us to that another challenge. So that's how we try to convince them that the safest place to have a seizure is the hospital. Like, no matter what, nothing would happen to you. Like, because people, especially with convulsive seizures, the generalized tonic-clonic seizures, they're at very high risk of something called SUDEP,
Yes.
sudden death in epilepsy patients, which is a very important entity that I feel like some people do not really understand, but it actually, epilepsy can kill you sometimes. So, like a lot of times, patients, when they're at home, they get a seizure and then they just cannot breathe anymore, their heart stops, and then they just die. So, in short, like that death in epilepsy is supposedly like the brain is actively working and the heart cannot really cope up with the like the increased need for blood supply to the brain. So probably that's the most like that's the proposed cause of death in epilepsy. So these things are usually prevented in the hospital. These things do not happen. So we make sure that we tell the patients every single thing. I know it's challenging to explain to them, especially when it comes to parents of children who have epilepsy. It's much harder to explain to them. But we try as much as we can, and the attendings, like they're great. Yep.
No, I'm glad to hear that you do discuss those issues with parents because I know a couple people who have lost children to SUDEP. And what was really heartbreaking, one of the parents, they decided because her daughter's seizures were controlled, they
Hmm.
decided to withdraw the meds and they did not tell the parents the risk of doing this. And she died in the middle of the night of a seizure. They found her in the morning and it was just, you could tell they're still at times in shock and then times just falling apart. The trauma that it endured on the family, it was really, really heartbreaking.
Yep.
So I really feel that one of the things that doctors need to make sure parents understand is the extra precautionaries that they have to take to prevent it. And then sadly, as much as you want to save everyone, you can't. There's, just some
Exactly.
cases that are just so bad that it's a risk and it just may happen. And it's so I think the education of it to at least make an effort to take preventative precautions is so essential.
Of course, and I would like to highlight on one of the preventative precautions that you were pointing at. So, what in the recent studies pretty much showed that SUDEP is related to patients having generalized convulsive seizures on their own when they're like unattended. So, like studies have shown, like if the patient who's been having seizures, it's better for someone to stay with them in the same room, or if not, in an adjacent room, so that if something happens, you can do at least like the first aid, like turn the patient to their side and so that they can prevent biting their tongue and make sure that the airway is secure until the ambulance comes, or and obviously give those rescue medications that we call intranasal, like benzos like midazolam and diazepam. So these help very well. And then it's sort of telling this to the parents makes a big difference because it can actually save lives. So yeah.
No, that's really good. I mean, myself, I haven't been on rescue meds for years, but they really, in some cases, they are very essential. They are life-saving. Myself, when I was in college, I didn't use the nasal spray. I was prescribed Ativan because I would get auras. So I knew if I was going to have a bad day and I was at high risk for having a grand mal seizure, I
Hmm.
could take the Ativan and pretty much I slept for the day. I think it was like it was a pretty large amount. It was 2 milligrams of Ativan, and pretty much it was to knock myself out so I could recover. But
Hmm.
there's plenty of situations I can think of in my life. If I didn't have access to my rescue meds, I wouldn't be here today.
Yeah, sure. I understand.
Well, for students like Aliana, what would you suggest to those who are interested in epilepsy?
Aliana, I think you're a final year medical student, right?
No, I'm still in my undergrad.
Oh, undergrad. Okay. So, are you interested in like epilepsy in the future? Like, do you want to become a neurologist, or like, what do you want to do like after med school?
I've been interested in neurology after getting into the internship and learning about epilepsy. I realized it's super broad, so it really sparked an interest.
Okay. So, basically, my advice for you is basically to be able to treat patients with epilepsy. You need to have that utmost passion for epilepsy, because if you don't have that liking, you will never enjoy epilepsy, and you will never ever be able to like treat patients well in the future. So if you're really interested in epilepsy, and you have the passion, then definitely go for it. Like, you need that passion. Epilepsy, I think, when you really like something, you'll be able to do great in it. And when you really care about the health of the patients, I mean, of course, there are other diseases too. And then I know other diseases like need different treatment, or like, all the everything pretty much needs care. But epilepsy is like a very complex sort of a thing. And to understand it and to be able to like excel in that field, you need to have that passion. That's like passion, passion, passion. Yeah.
I agree. And I feel like my passion has been growing like since researching about epilepsy and reading various articles about it, because I was really surprised because I only had the TV and like movie conception of epilepsy and seizures. So learning all this, it's amazing.
Yeah.
And
And I
you've done
wish
it.
there was more knowledge about it.
Well, you've done an awesome job with everything you've done with the foundation. And I just see if you do go further on for this, I know you're going to succeed at it. In the time you've been doing research for us, Aliana, is there something you feel we need to focus on more when it comes to information about epilepsy?
Yeah, I think it sort of just ties in what I was talking about, just the conception that's portrayed in entertainment. Because if you're not taught this in school or this information in school, the primary source of information is TV and television. And so the way that it's conveyed on there, I believe, is really crucial to the perception of whatever's being conveyed. Because like I said, I was very surprised at the various symptoms that are entailed in seizures and how easily like they can be overlooked, such as the ones in absent seizures. It seems like they're daydreaming, but in
They're actually
reality, they
not.
have a
Yeah.
lot. Yeah, there's a loss of consciousness. And because I've been writing an article about it, it's just learning about how it's very common in kids, and it just seems like they're spacing out a bunch of times a day, but in reality, it's being missed. And I
Yep.
think that's really important to know and expand, especially since epilepsy seems like to be the leading neurological disorder or most common neurological disorder.
Yeah.
No,
So
it's very true. And when it's going to come to educating for this, it's going to take more than just the doctors and families. It really, I feel we need to get into the schools, because situations like you said, if the kids are having absent seizures and the teachers are thinking they're just daydreaming and not
Yep.
caring about learning, that puts that child at such a disadvantage they don't deserve to be at. And with the protections we have, such as free access to public education and the IDEA Act, which protects children with disabilities so that they can have an individual education plan and really help them so that they get what they need to out of school. They get what they need from their childhood and don't allow a seizure disorder, epilepsy, anything to get in the way. I think it's just so crucial. And like you said, Aliana, with the way they look at it in the movies and TV shows, what they show on TV or in a movie and what reality is two totally different things.
Yep. Yeah. I just wanted to like just point one thing out really quickly. Do we still have time?
Oh yeah, absolutely.
Yeah. So when you were talking about like the epilepsy monitoring unit and the patients that we've been treating, I just wanted to point out, like, I want to tell parents like who have children with suspected epilepsy or anything, it might be psychogenic too. It's very necessary to admit them to the EMU because there are a lot of seizures. It's not just like convulsions, which are like very obvious. And then there are a lot of seizures in which you have loss of muscle tone for like 1 or 2 seconds. And then you lose tone, you cannot stand, and your head drops. This is like these are like different epilepsy syndromes, but like what I'm trying to say is like epilepsy can come in different like let's say different clinical presentations. So and every sort of epilepsy has a different treatment, and we've been able to like understand the pathology at the EMU, and we've been able to treat those patients with some certain medications that has actually like cleaned the EEG and has reduced the clinical features and severity of seizures. Because if they keep on progressing, it's very damaging to the brain.
Oh, absolutely.
Yeah.
And that's one of the things we created our YouTube channel along with having the blog articles. We have
Mhm.
our educational videos on the YouTube channel. And what we're trying to show our followers is these seizures affect everybody differently. And a lot of people, when they think seizure first aid, they think seizure first aid for tonic-clonic, and they
No.
don't realize there isn't just a one size fits all when it comes to helping somebody when they're having a seizure. I mean, myself now, I have complex partials. And the one dangerous thing about that is the best way I could describe it is when I'm having one, I come off as I'm drunk. I can't comprehend something.
Yeah.
So somebody, you know, you're not going to lie me down on my side and put a pillow or a cloth under my head to try to prevent injury. You're going to try to keep me calm and keep me focused and keep me from hurting
Yeah.
myself or putting myself in danger. And a lot of people don't realize it. And that's why we have a lot of the problems we do with helping people when they're having a seizure, especially in public. Because in a
Yeah.
situation like that, I mean, let's say the police were called. I could very easily get arrested and being accused of not complying with an officer's orders when really
Yeah.
I have no idea what's going on. So I think it is so essential to get the families educated and
Yeah.
show how important it is not to just keep this knowledge within a family environment, but our schools, our communities.
Of
So many
course.
people need
Yeah.
to know about this and how to help that person so that we don't have them get hurt or worse.
Of course. Of course.
But Aliana, as a student, what would you like to see when it comes to the care of patients with epilepsy?
After taking a bioethics course and hearing multiple stories with the consensus of like incivility between doctors and patients in some occurrences, I believe it's essential to cultivate a healthy space for physicians and patients to practice um, and to treat them as a close friend who wants to go to the extent to work together on the patient's healthcare, to build like a sense of transparency and to be able to establish thoughtful communication. Because I feel like that's where a lot of information gets lost is the way of communicating. Sometimes doctors can be, or physicians can be intimidating. So patients might not know how to convey exactly what they're feeling or what they're experiencing. And sometimes there's a disconnect. Um, in the bioethics course, some of my classmates and I agreed that the knowledge that a physician has can be very intimidating. And so I think just building that connection and trust and showing that we're both human, we're both here for your healthcare is really essential. And I think that can apply to anyone in any position, like what we were
Yes.
talking about, like teachers in schools dealing with those with epilepsy. It's just having the patience and compassion for everyone's healthcare and not to jump the gun and be impulsive.
Oh, absolutely. I agree with that 100%. And I think that's probably one of the biggest challenges we're having in not just healthcare system, but the education system at so many levels. It's how do you communicate this? How do you put a care plan together and get everybody on board? And that really is one of my goals that I hope to achieve with doctor-patient relations, because you know, well, it goes both ways. I'll be the first to admit times when I haven't been in the best of health and I'm frustrated and feeling overwhelmed. I'm not the easiest patient to deal with. And then and I've had thankfully some very compassionate doctors where when I was at that point, really helped me to look at the situation in a different way so that they could do their jobs and help me. And then there's been times it's been vice versa where the doctor pretty much gave up on me before giving me a chance, felt feeling, just go on disability. I don't have time for this, go on disability. And it really makes me happy to see the younger generation of doctors coming in now, realizing how essential communication is and that this is a team effort. It's somebody, the doctor is leading the team, but I think the doctors realize now to succeed at what they have to do, they have to be able to work with everybody on a team player rather than putting themselves at different levels. And it really makes me happy to see the level of compassion I see increasing now in the medical field that wasn't there in the 80s or 90s when I was a child.
Mm-hmm.
So, I originally wasn't going to ask this, but because we brought it up, Dr. Singh, working in the field, do you feel that there is a stronger level of compassionate care when it comes to working with patients with epilepsy? Do you feel that doctors, nurses, technicians can, I know they can't truly understand what someone's feeling, but do you feel that they can relate a little more to help keep a more calm environment to help people who are dealing with these challenges?
Of course, definitely. So whether it's the nurses, whether it's the doctors, whether it's the techs as well. So we all work as one team to be able to, understand the patient better. Sometimes, like, especially it becomes like a bit harder with children because, they're the ones who's sick, but like the people responsible for them, like their parents, are not. So like you, by treating them, you have to like be very careful with the parents as well, because sometimes like parents are in denial. They might not realize that, okay, fine, they might not accept the fact that our child is having seizure, or he has epilepsy or some problem. Um, and a lot of times they'd be like, in the middle of the week when they're admitted, they'd be just like, oh no, my son is fine or whatever. Because sometimes for 2 or 3 days, we don't find an answer until the fourth or fifth day.
Yeah.
So like they just want to leave in the middle. I don't blame them. I totally understand their psychology, their parents, they're very worried, and the hospital is not actually the best place you want to be in. But our job is to explain to them thoroughly that he might be having something serious. Of course, we'll be more than happy if there's actually nothing serious, but when there's a high suspicion, we try and explain to them very well. It gets very hard to explain to them sometimes. Some of them, they're not convinced, but we try as much as we can, think, especially when they get a seizure. We make sure that we interpret the semiology, the clinical aspect, and the EEG so well that we actually explain it in simple words to the parents to make sure that their child has a genuine problem of epilepsy. So it's a little bit hard, but I think we have a very compassionate team.
Oh, that's wonderful. And I think it's really is necessity now that we have that level of compassion.
Definitely.
Is there anything else either one of you would like to share today?
Just that epilepsy is really broad and
Yes.
it's not just convulsions.
Yeah, I think probably like one episode or one talk would not really do justice for that big, huge of a topic. But in brief, I hope we were able to like discuss certain aspects, and I hope like people will be able to sort of get some sort of a lesson or a message or some awareness regarding epilepsy. It's a broad topic, but we just touched on like some points, but there's a lot more to that.
Oh, absolutely, that there's. Well, that is all the time we have for today. Again, I want to thank our guests for coming and taking part. To see the great work we are doing, please like our social media pages and subscribe to our YouTube channel. We invite you to visit our website at www.defeatingepilepsy.org to see how we are making a difference for the epilepsy community. Thank you for your support, and together we will defeat epilepsy. Take care.
Sure. Thank you so much, Natalie and Aliana. Thank you.